Hello, good morning. My name is Alberto San Román. I'm a cardiologist. I'm coming from Valladolid. It's a pleasure to be here. I want to thank the organizing committee for inviting me to be up here sharing with you such an interesting, fascinating, and exciting topic as this one. First of all, let me introduce my co-chair. I have here with me Alberto Forteza, a well-known cardiac surgeon coming from the Puerta de Hierro Hospital. He's the chief of the Department of Cardiac Surgery. Eduard Quintana, who comes from the clinic hospital in Barcelona. He's part of the team of the endocarditis team in this hospital. And Pilar Tornos, a well-known cardiologist, as you know. We are taking advantage of her knowledge, so it's a pleasure to be here with you. Infective endocarditis is a devastating disease with a grim prognosis, the grimmest prognosis of all cardiac diseases, one of the grimmest prognoses of all diseases and grimmest than most types of cancer. So I congratulate the organizing committee for devoting this session to improve our knowledge in this devastating disease. We have been asked to change the format of the session, not to have a traditional session, but I would say a dynamic open session. We'll be asking questions, very specific, important, hot questions, relevant questions to our experts. They will give us some clues in no more than 5 minutes. After each question, we'll open the discussion. Please don't hesitate to take the microphone and ask questions. If you don't feel comfortable with your English, please just use the Spanish language. We understand rather well the Spanish, so no problem with that. But please help us to maintain a dynamic nature of the session. So let's start with our first question for Pilar Tornos. The question is, when should a patient with a recent stroke be sent to urgent surgery? A stroke and surgery, very difficult topic.
Thank you very much. We all know that neurological complications are devastating, and they occur in up to 20 to 50% of patients with infective endocarditis. We all know that they increase the surgical risk and increase mortality. The decision of the surgical timing in patients with infective endocarditis and a neurological injury requires a balance between the urgency of the operation for cardiac reasons versus the risk of exacerbation of the neurological injury by intracerebral hemorrhage, hypotension, or diffuse ischemia. What we need in those patients is a very early evaluation of the surgical indication for cardiac reasons in the endocarditis team, and we need a very early cerebral imaging in case of neurological symptoms, mostly by MRI. I think that the early involvement of a neurologist in the decision-making is crucial. And probably we need a neurologist in the endocarditis team. In fact, in Valle d'Hebron, we have incorporated a neurologist in the team in the last 5 years. And in her doctoral thesis, she could really show how the introduction of a neurologist in the team had decreased the mortality due to neurological causes in infective endocarditis. So I think that this is important. What do recent data show? Recent data show that the risk of postoperative neurological deterioration is very low after a silent cerebral emboli or TIA. Recent data also show that in most patients with ischemic stroke without severe neurological damage, early surgery seems to be beneficial with less risk of neurological exacerbation. And in cases of intracranial hemorrhage, the risk is high. Therefore, the recommendations are as follows. After a silent embolism or TIA, cardiac surgery, if needed, is recommended without delay. After a stroke, clinical stroke, cardiac surgery, if needed, is also recommended without delay as long as coma is absent, as cerebral hemorrhage has been excluded. After a cerebral hemorrhage, surgery should probably be postponed. And in cases of large rupture or enlarging infectious aneurysm, neurosurgery or endovascular therapy should be performed before cardiac surgery. Those are the recommendations that we have. And in fact, this is the algorithm of the European guidelines of infective endocarditis. That is, if you have a neurological complication, you need a very early clinical assessment with MRI. If the patient has cardiac situation that deserves surgery, as heart failure, uncontrolled infection, abscess, or high embolic risk, and the patient needs to be studied neurologically. If he has intracardiac hemorrhage, coma, severe comorbidities, or stroke with severe damage, probably he should be monitored and to treat conservatively. But if these neurological complications are not there, surgery should be considered.
Thank you very much. Any questions in the audience? Any comments, Dr. Quintana?
Sometimes we just go and offer urgent surgery after a stroke in patients that may have recovered entirely or not, and just go for surgery and implant, for example, a tissue valve. And we always worry about transformation into brain bleeding, which it happens, regardless of what you do, even if the operation is short and things go well. The question is, in our center, we're now starting to be more active in the sense of looking for small septic aneurysms that can sometimes be difficult to detect with CT scans or MRI, and sometimes we just go even after surgery, even if there is nothing new neurologically. We've done several angiographies to try to spot things that otherwise clinically or with other tests wouldn't be spotted. Do you think it's something that we have to be very active after surgery, even if they don't have problems that are evident, to look for this and treat it before something wrong really happens? Because we will remember 1 or 2 cases that, every 50 patients transform into bleeding.
Yeah, I think that this is really difficult, and in fact, can you hear me? In fact, Dr. Habib, and there will be a recent paper that in circulation about imaging in infective endocarditis, in which he's very strong in favor of that. I have my doubts, but he's very much in favor that even a patient without neurological symptoms, that it's sent to surgery because of infective endocarditis, urgent surgery, should have an MRI performed before surgery. And probably he's right, because although there's no clinic, there are some evidence, there's been some papers saying that those cases can have prognostic implicances. So I think that we need to be very, very pro the diagnosis of neurological complications, and then discuss with a neurologist the opportunity, and also to make sure to individualize the patient. I mean, if the patient is really dying because of heart failure, that's very different than if the patient has a paravalvular abscess that you can perhaps wait a little bit. So we need to individualize. But I think that if the patient really needs urgent surgery, very urgent surgery, and the stroke, the data are there. I mean, if there is no coma, if there is no hemorrhage, I think that the literature suggests that the benefits of cardiac surgery are much better, much higher than the risk of neurological problems.
I have a short question. There are 3 indications for urgent surgery: heart failure, persistent infection, and prevention of embolism. I think this one is the weakest one.
Yes.
In all the indications, the size of the vegetation is a very important parameter to be taken into account, but the cutoff points are absolutely arbitrary. And I'm a specialist in imaging. I can give you, with the same patient, I can give you a 15 millimeters diameter vegetation or a 9. It depends on the mobility and many things. How confident do you feel when you have to decide, depending on the size of the vegetation? How confident are you with that sign?
Well, in fact, I think that in our endocarditis team, it's not only my opinion, but the opinion of the team, which is very active in the hospital. I think that we have not sent a single patient to surgery only because of the size of the vegetation. We probably would consider it if the vegetation was extremely large, say 3 centimeters, as the paper by Cabrera showed in circulation. But only because of the size of the vegetation, probably not. I think that in infective endocarditis, it's very rare to send a patient to surgery for a single reason. Because normally there is a mixture of things. You have a large vegetation, you have a difficult organism, you have severe valve disease, even if the patient is not in heart failure. And this is this mixture of things that who really put the patient to surgery. But very urgent, it's only heart failure.
Okay, next question is for Dr. Quintana. Extensive infective endocarditis with aortic valve, mitral valve, and fibrous body extension is a very complex disease, and on the other hand, it is more frequent, we'd like to find in these patients, and the question is how to treat this condition.
Thank you for the invitation to talk here. So these are cases that usually we all know that we're talking about aortic root invasive endocarditis that can have different degrees of involvement of the mitral valve, and certainly a lethal disease. Many of these patients will not, or almost all of them will not leave the hospital without a very aggressive operation. This is a kind of a surgical view of the situation that you would have in a patient that you are dealing with intervalvular fibrosa resection. This is the intervalvular fibrosa that has been divided here. You see the aorta opened, going across the annular aortic annulus, going through the roof of the left atrium, and everything becomes a common chamber. This is the mitral valve on top, and if you have resected the anterior leaflet of the mitral valve, this is what will be left. The annulus of the mitral valve and the annulus of the aortic valve. So to try to standardize a little bit how to approach these patients, the way we like to look at is to look at the extension of root disease. Is it completely destroyed and does it need entire root replacement, or just part of the aortic annulus is destroyed? And then the intervalvular fibrosa, is it destroyed completely? The mitral valve, does it preclude repair, the amount of disease that you see there? And this, if that's the case, you have destruction of only a part of the aortic root annulus, you have destruction of the entire intervalvular fibrosa, and a mitral valve that cannot be repaired. Can we run this clip here, please, if you click? This would require an operation that have to replace both valves. The way we do it is first we secure, after resecting all the infected tissue, you secure a mitral prosthesis from trigone to trigone posteriorly, and then you have to reconstruct the new intervalvular fibrosa, which we usually can do with a bovine pericardial patch. This is the new intervalvular fibrosa distance. It's done with a patch after the mitral valve is implanted, and then, you secure an aortic valve prosthesis like you would do in an aortic root enlargement. Sometimes situations are even more advanced, and the root disease is so extensive that you need to replace the entire root with a root conduit, either an homograft or a mechanical valve. And this is what we call a root commando. This would be the same setup that you've seen before. We implant the mitral valve, and then you reconstruct the intervalvular fibrosa with a pericardial patch, and on top of everything, you put an homograft or a root conduit. This is an example of a case with such degree of destruction. Can we play this one here? Just click on top of this. Here you can see destruction of the intervalvular fibrosa. This patient had a root aneurysm. You can see the aortic valve bicuspid and completely destroyed. This is the intervalvular fibrosa here. The head is here. Legs are here. You can see this amount of destruction that precludes any repair of this mitral valve. The access is through the roof of the left atrium. You resect the anterior leaflet of the mitral valve and the intervalvular fibrosis that are involved in the infection process. You secure a mitral valve from trigone to trigone, and this is the new intervalvular fibrosis that will need to be reconstructed with a bovine pericardial patch. We are sizing it. The video obviously is running fast for the sake of time. And then once this is reconstructed, use this leaf to close the roof of the left atrium. And on top of everything, we would insert a root homograft. Coronaries are reimplanted and the heart is beating again. So just to finalize this one, so there are many ways in you can do this, but these are usually operations that are required to grant survival in this very extensive disease. And if the mitral valve is involved, even if it's not completely severely involved, both leaflets, sometimes you may need to replace it to simplify the operation. And I have put our series here with Alberto to show that these operations can be done with very acceptable survival if things are done in a similar way. Thank you.
Okay, thank you. Any questions?
Well, really impressive.
Yeah, thank you very much for this excellent revision of this technique that I suppose most of you didn't know. And really this is a challenge condition for surgeon, and it's a situation that many times we find in patients with endocarditis. My question is for both, for Dr. Quintana and Dr. Tornos. In this high risk surgery, how do you suggest to organize this surgery? Only in specific centers of cardiac units, very experts in endocarditis, only performed by specific surgeons in some units? What do you think? How to organize this surgery?
Well, one of the problems we see is many of these patients that we have seen it in many institutions are not offered an operation that can be life-saving, because some surgeons consider this sometimes to be too advanced or irreconstructible. And I think we have never turned down a patient for impossibility or technical impossibility to reconstruct the cardiac structures. But it's very difficult if you have a very unstable patient to move this patient to another center. So that would be a very huge limitation. I think we as surgeons have to teach this operation in a way that can be reproducible. It's not easy. You know that sometimes you find things and you have to innovate, and you learn in every case that you do with this. So it's quite difficult to have a very reproducible approach that can be used by any surgeon on call. So, but if the patient could be transferred, that could be an option.
Maybe we have to start thinking in a different way. Maybe we have to move experts from one institution to another instead of moving patients.
I think so. I think it's something that's very important. I mean, surgery in infective endocarditis is extremely difficult in those cases, really. Sometimes we discuss whether the patient needs a transplantation, because I don't know whether you perform that sometimes in case that you cannot really reconstruct. But I think that it is something that has to be considered, because sometimes we have those very difficult patients with very urgent surgery, and I think that it's a surgery that cannot be done probably on emergent basis by the surgeon on call, because those surgeries are really very, very demanding, and I think that they should be planned perhaps very rapidly, but they need to be planned and performed by really expert surgeons, because sometimes we as clinicians, they don't want to operate, and then we feel very upset because our surgeon doesn't want to operate and the patient is dying. But I think that sometimes they cannot operate things that are so difficult.
I agree. Many times clinicians and cardiologists stress us to operate these patients in bad conditions, and for the patients, many times it's much better to wait until next morning and be operated by an expert team. And your point, I think, is a point to consider. And also, many of these patients are referred from other hospitals, and in these cases, maybe should go to specific units.
Okay, let's move on to the next question. As you know, one of the most challenging decisions in clinical practice is whether to send a patient or not with acute infective endocarditis, and which is the time. To this, sometimes we use surgical scores, but we know that the usual scores are not useful in this setting. So the next question for Pilar Tornos is, what about surgical scores in active infective endocarditis?
Okay, we know that surgical risk scores are an essential tool for predicting and evaluating the results of cardiac surgery. We'll agree with that. However, we know also that there are conflicting results regarding the predictive ability of the Euroscore and STS in infective endocarditis. Dr. Mestres from Hospital Clinic was the one who probably published the first paper on that. And after that, there has been other papers who really stress how there are a lot of differences between what the ST or Euroscore predicted and the real mortality in infective endocarditis. And the reason is that because the most significant independent predictors of postoperative death in infective endocarditis are very specific for the ES setting, and they are not included in the most commonly employed prognostic systems, as vegetations, paravalvular damage, infective organism, or whatsoever, probably are more important than other variables that are included in the usual score systems. There are small studies that have tried to derive score systems from infective endocarditis controls, but they are with a small number of patients and without, it's not really applicable. But very recently, there have been important studies addressing this issue. This is a paper by GACA using the ESTS database with more than 13,600 patients with infective endocarditis. And they included some variables in the model as urgent, cardiogenic shock, etc. It's quite a good score, but however, one has to say in this study, over 50% of the patients were not really active infective endocarditis. This explains how the mortality of the whole series was only 10 or 12%, which is very, very low when we consider active infective endocarditis. And also in this STS infective endocarditis score, no infective endocarditis variables such as microbiology or anatomic data were included. In Spain, there was one paper by Martinez-Selles, which published in the International Journal of Cardiology, that was a multicentric study, and he included variables like prosthetic valve, age, intracardiac destruction, aureus, urgent surgery, Euroscore, and he provided a score that probably was better than Euroscore in the assessment of the risk of infective endocarditis. However, there was no internal validation. And also, there are some variables as age or sex that were also included in Euroscore, so one was not really sure whether this score could really work. I think that this is a very important paper from the group of Valladolid, of Alberto and Román. Dr. Olmos published a paper which I think is very important in Heart last year. They studied 671 infective endocarditis treated surgically during the active phase, And they disclose a development sample, a calibration sample, and also they perform an external validation. And they included in this new score specific for infective endocarditis the variables of age, prosthetic infection, Staph aureus, acute renal failure, septic shock, cardiogenic shock, and thrombocytopenia. Those were the variables that, after assessing the prognostic variables in the sample, were chosen. And as you can see here, the predicted risk and the observed risk of the entire cohort, that's the calibration, work very, very well. And also when comparing their score, which is the one here, with the other scores, like the one by MSJS or the ST score, you can see how the area under the curve improved. So probably this score offers benefit, and we might be using it in the future. However, our group, even more recently, has used another strategy that it's going to be published very, very soon. It's also a multicentric study of more than 700 patients that were treated surgically during the active phase. And what we did was to simplify the Euroscore 1 and 2, eliminating variables that we considered that were irrelevant for the infective endocarditis patients. And we added specific infective endocarditis variables, like location of the infection, etiology, presence of paravalvular complication, vegetation, days in hospital until surgery, and the Charlton index. And then we compare the original recalibrated and specific scores. What we saw is that the net reclassification index was 5.1% for the Euroscore 1 and 20.3% for the Euroscore 2. It's a pity that we didn't work together, because I think that we should probably validate either our study or the study for Valladolid. But what is really clear is that in order to assess the surgical mortality, the Euroscores or the scores are not useful. We should incorporate variables specifically dedicated to endocarditis, and probably is to validate our cohorts, either by using your score or ours, which are probably different ways of approaching the same problem.
Well, any question? Scores in endocarditis, surgical endocarditis? Well, I would say that many times I think we feel that we get late with these patients. When we decide to operate the patient has shown us many signs, many parameters that of poor prognosis. I would ask if we should undergo surgery just by looking at those high-risk parameters, although there is not a clear indication for surgery in that moment.
I completely agree. And regarding the scores, I think that scores are interesting, but they are not going to help us to decide. I mean, I think that scores are good for research in order to compare results of surgery from one group to another group. I think that they also help to assess the risk, but the risk, you know the risk of your patient, even without score, probably. It's good to have it, but you will not decide whether to operate a patient or not to operate a patient because of the score. That's my opinion. I don't know what the surgeons think. I think that scores are good for the interpretation of surgical results, and for it's a tool to help to compare surgical patients, but to decide, I don't think they help. I
agree completely. They may only be used maybe to benchmark institutions or teams, but you're never going to reject or accept a patient on the basis of a number. And in fact, in our endocarditis team meeting, we don't even talk about Euro scores or whatever. You may reject the patient with very low Euro score for whatever particular reason, or accept patients with a 90% Euro score to risk of death.
So it's just another piece of information you have to take into account in the whole picture of the patient.
Okay, let's move to the next topic. Actually, homograft and biological prosthesis seem to have a more resistant capacity to reinfection in these patients, but on the other hand, homografts can generate and reoperate the patients with this condition. Is a very high-risk surgery. So my question is if there is still controversy between the type of prosthesis you should use in this patient, mechanical, biological, or homograft.
Okay, thank you. From a surgical perspective, I can answer right away. No, there's no controversy. So it's quite clear in the vast majority of patients what to do. This is endocarditis, and this is what I was talking before. This is an example of a patient that had an urgent operation without previous neurological nothing detected on imaging or clinically, and we did a aortic valve replacement with 35 minutes cross-clamp time, less than 1 hour on pump, and 5 days out of surgery with a normal lapse, normal hemostasis. He was only on aspirin. That's what happened. He had to be taken to the neurosurgical room to decompress a large hematoma. Luckily, we were able to have him alive, and he's still recovering. So we know embolism is very frequent in endocarditis, and if we were to do MRIs in every single patient before an operation or after the operation, we would see that even up to 80% of them would have things seen in the imaging tests. The problem is we are not able to predict which of these patients that have no brain bleeding before surgery will transform into brain bleeding. And thus, if we know if they have something on the brain, our policy is not to use a mechanical valve, either an homograft or a tissue valve or whatever, but nothing that requires anticoagulation after surgery. And I go a little bit farther. If you don't have data because you have taken the patient emergently to the operating room, or you don't have any CT scan or MRI, you would go again for a tissue valve if you have seen systemic embolisms before surgery, or if they have poor ventricular function, things that can, or a very high complexity operation, things that can put the patient at risk of mechanical circulatory support after surgery. I think that simplifies the management after surgery. If they are in very poor clinical condition, you don't want to anticoagulate these patients after surgery, so you choose a tissue valve as well. And if you expect problems down the road early after surgery, same thing. We really don't have data on relapses related to valve surgery. All that we have is retrospective, so it's very difficult to draw conclusions from what is in the literature. Guidelines tell you that if you have resected the infection and the annulus is okay to secure a valve, you can use a mechanical or tissue valve, provided that you can secure safely these valve substitutes. But if the annulus of the aortic valve is very extensively destroyed, then an homograph would simplify the operation. The homographs are very useful, we know that, but the problem in many places is availability. We in Catalonia, we don't have this problem. You can give a call, and in 1 hour or 2 you can have the homograph in the operating room. I think that simplifies our management, but I know many of our colleagues have problems elsewhere with this. It's a very good substitute because it simplifies the reconstruction of aortoventricular discontinuity, and it's very forgiving in terms of hemostasis after surgery, much more than other valve conduits. It offers excellent hemodynamics. That's what you want after operations that may be very long and very complex, but the problem is the durability. We know that. And this is particularly true for young patients operated in the setting of endocarditis. You see that after 10 years, many of them do need a reoperation for a structural valve deterioration. This is a very important problem, but again, we're talking about getting these patients out of the event, so we can still do something about that down the road if they require an operation. We are working on developing homographs that are decellularized and with the thinking that they can be recellularized by the own patient with time. And we would like to see this to be applied in the endocarditis field. I think there may be a role of this sort of homographs in the future there. They can be stored for a while, not very long, but they can be stored. It will be useful in this young population that requires homograph replacement. But I think we have to move a little bit forward and maybe try to think not to replace the valve. If you can try to spare it, it's always good, particularly in the mitral position. Can we run this one here? This is an endoscopic view of mitral valve endocarditis, and not only moving towards repair. We can even think about moving towards minimal invasive mitral valve repair. But this you have to be really sure that you are not talking about invasive endocarditis. That would be really a problem. So controversy, not really. So if there is annular destruction or ventricular aortic discontinuity, you would go for an homograph. That's what we propose. The patient acute characteristics, the complexity of the operations would dictate to go for a tissue valve. And then if you have problems with homographs, there are other things that can be used in the market, but probably are not that forgiving in terms of hemostasis. If you have doubts on brain issues after surgery, tissue valve, we don't really know whether mechanical or tissue valves help in avoiding relapses, which are in fact very infrequent in centers that deal with these patients. We barely have any recurrence of infection after surgery. And at the end, if you know they don't have problems with brain embolism or brain issues, it's still the same principles that apply to valve decision in other settings that are not endocarditis can apply in here. But if in doubt, we always go for tissue substitutes.
Thank you. Any questions? Okay, Dr. Quintana, do you think maybe the most important to do for surgeons in this patient is to be very aggressive in the resection of all the infected tissue, as you saw us in the your first talk? Maybe that's the important point in this surgery, to resect all the infected tissues, more important than the type of prosthesis you decide to put.
Yeah, absolutely agree. That helps in avoiding recurrence, and even not only resect clearly infected tissues. If there is something suspicious, you are not macroscopically, you don't have a real security that this is clean. You just go and resect it and replace it as well. So if in doubt, be more aggressive than conservative. That's the surgical principle.
I also think that the choice of the valve, probably Habib is right. I mean, and every single patient going to surgery in active infective endocarditis, irrespective of if he has or not has neurological symptoms, should have an image of the brain, because I think that this will not only, if the patient needs surgery and he's asymptomatic, probably he will go for surgery anyway, but the risk will be more clearly assessed, and the choice of the valve will probably have an impact, because it's difficult to put a biological valve on a 20-year-old, but perhaps if he has something in the brain, it's a good decision. So I think it's a wise idea.
It's a complex decision because you have to balance many scenarios in this patient. You have the brain, you have the complex, very complex surgery in some occasions. For example, if you have to do a very complex reconstruction, maybe to put a biological prosthesis, put a very important risk in few years to this patient. You have to balance both.
Let me just reply to this. I agree. When you face situations like the ones I showed in the first video, you wonder, what's going to happen with this patient, 10 years down the road. This patient was a very young patient, for example, but his LV was not that good. He came in a very poor condition, and what you want at that precise moment is to get the patient out of the hospital alive without problems. You are not thinking about 10 years down the road. You'll be happy to deal with whatever comes down the road. It can be percutaneously, it can be a very huge operation, it can be a heart transplant, I don't know, but I just want to get the patient out of the hospital safely. And replying as well to Pilar, I think it's not only important in terms of deciding the valve choice, having preoperative imaging. I think it helps you manage patients in a way that is much more individualized. For example, if you know they have even minor things, you may not give aspirin, for example, after surgery. You may keep the patient without aspirin, something that you wouldn't do in another scenario. Or if he has atrial fibrillation after surgery, you would skip anticoagulation. I mean, there are risks that have to be taken with that. And it's always a balance. So even after surgery, you are much more aggressive in the ICU to treat low platelet counts, for example. So these are things that we do routinely. We keep a close eye on all these sort of things, and I think that helps reducing problems.
There is one question from the audience.
Just, I had two quick questions. One, you've just answered about antithrombotic treatment in the postoperative phase of these patients, and I also totally agree with you that many of these patients should not receive aspirin or anticoagulation, even in situations that usually require them. And another question is about, my question was about neurological monitoring in the postoperative phase, and I'd like to know how you do it. I'm much in favor of aggressive neurological monitoring after surgery, but I'd like to know your opinion.
It's decided on a patient individual basis, but I think it's very useful to have imaging, even if they don't have any symptoms, a few days after surgery, because that will help you guide whatever. If you've done a very complex operation with several valves, even if they're tissue valves, you may consider anticoagulation if they don't have anything. So if they're 2 weeks out of surgery and everything looks fine from a brain standpoint, then you can add anticoagulation. That would help. And in some patients, I remember one patient recently that came with a previous stroke, and he got the operation done urgently. After surgery, he recovered entirely from a neurological standpoint, and we were thinking whether to anticoagulate him or not. So he underwent a diagnostic cerebral angiogram to make sure there were no problems before starting any anticoagulations because of the perceived risks that it can be, transformed into brain bleeding. So, but we are still debating this in our heart team with the neurology involved as well.
I think that if you are lucky and you can have a neurologist in the team, that's excellent. Because we are not sure when to start anticoagulation, when to perform an MRI, whether a CT, the timing of all that. If you are lucky and you can put emotion in a neurologist so that he can devote himself to endocarditis, that's excellent for the safety of the patients.
Okay, let's move on to the last question for Pilar Tornos. As we said, we feel that the clinical picture in endocarditis is going faster and worse than we think. So, do we have clinical markers of poor short-term outcome?
Well, I think, as Alberto said, infective endocarditis is a terrible disease. On top of that, it's a rare disease. That means that not everybody knows how to handle it. And we all know that probably the only chance that patients have when they are very sick is to have a rapid diagnosis and a rapid decisions made. I think that the rapid identification of patients at higher risk is the only way to improve outcome, because that means that if you identify that, you can refer patients to hospital with surgical facilities, with endocarditis teams, and to have early surgical advice. How can we do that? I think that at the time of diagnosis, we can really approach prognosis quite easily, because the prognosis of infective endocarditis depends on the patient characteristics, such as age, comorbidities, the presence of diabetes, renal failure, thrombocytopenia. It depends on whether at the time of diagnosis the patient have complications, either cardiac, or heart failure, or non-cardiac, such as neurological or others. It depends on the infective organism. It's very different to deal with a Staph aureus endocarditis or Streptococcus viridans. And it depends on echo findings. And we have all this information at the time of diagnosis. So we should make our decisions at this very early moment. I think that there is a paper from Román, which I think it's very important. He showed how we could stratify the risk of patients at admission. And this is, I think, an important paper on more than 300 infective endocarditis, on which 76 prognostic variables were assessed on admission. And the variables in the model that were finally chosen were the presence of heart failure on admission, periannular complication, or Staph aureus infection. And they provided a risk score. That was that if you had any of those, your risk of infective endocarditis was 25%. If you had one of those, the risk increased up to between 38 to 49%. If you had two of those, it was very high, from 56 to 65%. And if you had three, it went up to 79%. So I think that those are really the sicker patients that you can have. And it's interesting that this score had an external validation in which our patients from Valle d'Hebron were included. And the model was found applicable to different hospital cohorts. This is an example, but I think it's a clear example on how, on admission, you can have variables that are present there, that are easy there, and you can really stratify your patients. So I think that this is important, because I think that if you have an infective endocarditis in a secondary hospital, and it's a risk endocarditis, should be immediately be sent to a center with surgical facilities, immediately. And there is another paper also coming by the Valladolid group, which is also important. That means that besides the presence of heart failure, Staph aureus, or periannular complications, if blood cultures remain positive, when you repeat them from 48 to 72 hours, that's a marker of bad prognosis. That means that we have to be very careful on admission to really select the patients who we know that they have a bad prognosis, and we have to follow them very closely in the next 24, 48 hours. And if blood cultures are still positive, probably we're advancing the diagnosis of persisting infection. We can accept that if a patient is having the antibiotic treatment that he deserves, because the blood cultures show that. But blood cultures are still positive after 48, 72 hours of treatment. That's also a marker of bad prognosis and means that we have to be very proactive and consider surgery.
Okay, thank you, Pilar. One short question.
The question is, if the patient has no markers of poor outcome, can this patient stay in hospital without surgical facilities, or do you think that every patient with endocarditis has to be in hospital with surgery?
I think that if they stay in a local hospital, they need to be in contact with an endocarditis team. That's what we do in our area. I mean, we have patients who stay in their local hospitals if they had moderate mitral regurg, small vegetations, streptococcus, endocarditis. I think that they can be there. But we try to assess the prognosis at the time of diagnosis, and we also try to help them with any question they might have during the course of the patient. And if some complication arises, they have high priority to be sent to our team.
Okay, last question is for Dr. Quintana. We all know the indications for operate this patient, but the question is which should be the best timing to operate? And I think this is an important question.
The earliest the possible. That's the answer. I know we're running a little bit late. So when you are dealing with the decision to operate on these patients, you always have this in mind. Too early, you have problems. You don't have enough data, you don't have knowledge about the coronary status, you don't know how the aorta is, you may have problems with homographs in certain places, some patients may have more coagulopathy, you may have problems with the on-call team, you may not like whoever is going to assisting you, I don't know, many things can happen. You know that operating too early sometimes may be associated with brain bleed, although it is not that clear. But if you operate too late, you have the other thing. You'll be waiting with patients with large presentations, you will have a CVA. If you wait too much, there may be ongoing destruction that makes things even more difficult for surgeons. I don't see a reason to wait for the antibiotics to clean the inside of the heart. Tissular destruction is worse always with time. And if you wait too much, patients start having other problems. They start having problems of being in the hospital. They get colonized, they get weak, they don't eat well, all these things. And at the end, you are facing an operation with a patient that has lost a lot of biological reserve. So that's, in my mind, these are things that push me to operate earlier than later. This is an example of a patient that came with a stroke, and he partially recovered, and he had this large vegetation with severe aortic regurgitation. I'm not going to run the videos for the sake of time. So with these situations, which are usually those that pose more difficulty in deciding what to do, you have the problem of the neurological exacerbation after surgery, and you end up deciding what is best, to operate early and prevent embolism or have issues with the brain after surgery. Usually we go for surgery with these cases if there is still risk of embolism in an urgent basis, and you have to be able to adapt and change the caseload or the cases during the day. And even if you've done an endocarditis, you put another one. This day we did 3 endocarditis. But you need everybody to be really engaged and willing to change, and so there needs a huge amount of people and a good team willing to do things for the benefit of patients. What we do in our hospital is we are not going to discuss whether surgery needs to be done quicker in the presence of heart failure. Everybody does that. But this is the area where more discussion comes, whether to operate very urgently or emergently or wait a few days. What we do is on patients that have had a stroke and they have still a large vegetation, more than 1 centimeter, we go for emergent surgery. That means not waiting 2 days. That means the same day. Same thing for patients that have aortic regurgitation or mitral regurgitation and still have large vegetations. We don't wait with these patients. We just go for surgery, even if they're high risk. We're not going to wait 1 week. What's the point in waiting? You may have a stroke, so that's our current policy. By doing that, and I just reviewed quickly our last 110 cases operated in the acute phase of the disease, this is left-sided endocarditis, you see that 20% were operated during the first 20 hours of hitting the hospital, and 50% got operated in the first week. By doing that, our mortality after surgery at 90 days or in hospital is 7%. So I think that really helps in avoiding problems, and I mean, this is not a randomized, this is only our clinical experience, but I think it really helps to minimize mortality by having patients waiting until an operation that is being delayed.
Okay, thank you. Well, we don't have time for any question. We are out of time. So I think it has been a very interesting panel with a very nice discussion. And thank you very much, all of you. Now it's coffee time. Thank you. Bye.